Here's a pro tip. If you don't understand how a disease works, you'll likely get the USMLE question wrong. Welcome back to MedUPTICK, Physicians in Training. I'll tell you a secret. Most students think H. pylori directly eats away at the stomach lining, but what if I told you that's not how it actually causes damage? Since this is a common misconception, let's break it down now. Which mechanisms best explain how the underlying pathogen contributes to this patient's gastritis? A 52-year-old man presents to the clinic with a burning, gnawing epigastric pain that has gradually worsened over the past few months. The pain often occurs on an empty stomach and seems to improve slightly after eating. Right away, we have been given a classic symptom pattern that strongly suggests peptic disease, either peptic ulcer disease, PUD, or gastritis. Burning, gnawing, epigastric pain. This description is classic for ulcer type pain. Gradually worsened over the past few months, a chronic process pointing to persistent mucosal injury. Occurs on an empty stomach and improves with food. This highly suggests duodenal ulcer or gastric inflammation, both associated with H. pylori infection. Here's an important distinction. Gastric ulcers often worsen with food due to acid secretion increasing after meals. Duodenal ulcers typically improve with food because bicarbonate secretion is stimulated. So we are dealing with a chronic upper GI disorder, potentially H. pylori-induced gastritis, peptic ulcer disease, or functional dyspepsia. He also has experienced intermittent nausea but denies vomiting, melena, or hematemesis. Nausea is nonspecific but common in chronic gastritis. No vomiting, melena, or hematemesis. No hematemesis suggests no active GI bleeding. No melena, black tarry stool, suggests no significant upper GI hemorrhage, which makes bleeding gastric ulcers or malignancy less likely. No vomiting argues against gastric outlet obstruction, which could be caused by pyloric stenosis due to chronic ulceration. I'll give you two high-yield insights. H. pylori can cause both duodenal ulcers, which are more common, and gastric ulcers. Gastric ulcers have a greater risk of malignant transformation, such as adenocarcinoma. His medical history includes hypertension, for which he takes lisinopril. He drinks 2 or 3 alcoholic beverages per week and denies smoking. Lisinopril, an ACE inhibitor, unlike NSAIDs, does not have a direct link to peptic ulcers. Let's clarify some details about alcohol consumption. Moderate alcohol intake, 3 to 4 alcoholic beverages in one day for men, is not a major risk factor for gastritis unless deemed excessive, which is classified as 5 or more alcoholic drinks in a day or 15 or more per week. Chronic alcohol abuse can lead to Mallory-Weiss tears, which are mucosal lacerations at the gastroesophageal junction, or acute erosive gastritis, but this patient's consumption is mild. We know smoking history is a known risk factor for peptic ulcer disease because it impairs mucosal healing. However, he denies smoking. Key takeaways. NSAIDs and smoking are the most significant non-infectious risk factors for peptic disease. Since he doesn't take NSAIDs and isn't a smoker, we should strongly consider H. pylori gastritis. His family history is unremarkable for gastrointestinal cancers or autoimmune conditions. No family history of GI cancers reduces the suspicion for hereditary gastric cancer syndromes, such as Lynch syndrome, Li-Fraumeni syndrome, familial adenomatous polyposis FAP. No autoimmune history makes autoimmune gastritis, atrophic gastritis due to antiparietal cell antibodies unlikely. Here's another high-yield insight. Autoimmune gastritis is characterized by pernicious anemia, vitamin B12 deficiency, and achlorhydria, which results from the destruction of parietal cells. On examination, his vital signs are within normal limits. Upon palpation, he has mild tenderness in the epigastric region, but no guarding or rebound tenderness. Epigastric tenderness is expected in gastritis, peptic ulcer disease, and pancreatitis. Pancreatitis is not a differential for this clinical case based on his prior medical history and the lack of pain radiation to the back. No guarding or rebound means there is no evidence of perforation or peritonitis, such as perforated ulcer, gastric carcinoma invasion. Laboratory tests reveal a normal complete blood count, and liver function tests are within the reference range. Normal CBC confirms no iron deficiency anemia, suggesting no chronic GI bleeding. Normal LFTs rule out hepatobiliary causes of dyspepsia, such as gastric varices due to portal hypertension. The key takeaway here is the absence of anemia or significant bleeding makes severe ulcerative disease or malignancy less likely. An upper endoscopy shows erythema and erosion in the antrum, but no frank ulceration. A biopsy is taken for testing, and pathology reveals signs of chronic gastritis. Erythema and erosion in the antrum is highly suggestive of H. pylori associated gastritis because it primarily affects the antrum before spreading proximally. No frank ulceration rules out full thickness peptic ulcers, reinforcing a diagnosis of gastritis rather than peptic ulcer disease. Remember, H. pylori initially colonizes the antrum and induces an inflammatory response, leading to gastric mucosal damage over time. Chronic infection increases the risk of peptic ulcer disease, gastric cancer, and MALT lymphoma. Which mechanisms best explains how the underlying pathogen contributes to this patient's gastritis? Before looking at the answer choices, let's consider 3 plausible differentials in summary based on this vignette. Number 1, H. pylori associated gastritis. Based on this patient's symptoms, endoscopic findings, and chronic course, which are supported by biopsy findings of chronic inflammation, this is the most likely cause. Number 2, NSAID-induced gastritis. This would have been a probable diagnosis if the patient had been taking aspirin or ibuprofen. However, he is not. 3, autoimmune gastritis. This is less likely due to no evidence of B12 deficiency, achlorhydria, or autoimmune conditions. Now that we've honed in on a diagnosis, let's select the best explanation for how the underlying pathogen contributes to this patient's gastritis. A, production of enterotoxins that inhibit water absorption in the stomach. This answer is incorrect because it describes toxogenic bacteria like Vibrio cholera and enterotoxogenic E. coli, ETEC for short, which cause secretory diarrhea, not gastritis. Answer choice A is eliminated. B, cytotoxin release causing gastric mucosal damage. This answer choice is partially correct. H. pylori produces cytotoxins such as CAG-A and VAC-A, contributing to mucosal inflammation. However, as demonstrated in the month-long vignette, cytotoxins do not contribute to chronicity. Therefore, they are not the primary mechanism of survival and persistence. Nevertheless, we will keep this answer for now. C, direct destruction of parietal cells. This describes autoimmune gastritis. As discussed previously, instead of H. pylori, hence, we will eliminate this answer choice. D, production of urease, allowing bacterial survival in acidic conditions. H. pylori produces urease, hydrolyzing urea into ammonia. This neutralizes stomach acid, increasing the pH range from 1.5 to 3.5 to 4.5 to 6.5 with H. pylori infection. Altering the pH allows the bacteria to persist with colonization, triggering an inflammatory response, leading to chronic gastritis. E, stimulation of parietal cells leading to increased acid secretion. Sticking to our underlying diagnosis of H. pylori infection, we know that H. pylori decreases acid secretion over time, particularly in gastric dominant infections. Since this answer choice aligns more with Zollinger-Ellison syndrome, we will eliminate it. This leaves us 2 answer choices, B and D. Answer choice D best answers this question because it most strongly contributes to the chronic gastritis this patient presents with, based on urease production, allowing bacterial survival in acidic conditions. The final takeaways from this question are 1, H. pylori causes gastritis by producing urease that enables it to survive in the acidic stomach. 2, chronic H. pylori infection leads to gastritis, peptic ulcers, and increased cancer risk. And 3, endoscopy with biopsy is a gold standard for diagnosis, although stool antigen and urea breath tests are also used. If this breakdown has helped solidify your understanding of H. pylori gastritis, please like, comment, and subscribe to MedUPTICK. We have free high-yield PDFs available for download, and we're giving away a prize at 500 subscribers, so don't miss out. Until next time, stay sharp and focused, and continue to elevate your clinical mastery.